I'll pivot and move to introduce our colleague, Dr. Fernandez, who is a member of the critical care and trauma team. Dr. Fernandez is a board-certified general surgeon in trauma. He's originally from Colombia and went through his training in Colombia and then repeated his general surgery and trauma training through Alabama and Tennessee. He has been a wonderful addition to the Department of Surgery, has several publications in GI surgery, trauma surgery, and has a particular interest in SICU and served in that capacity. I believe 2 years ago you won the teaching award by the students for going above and beyond at the recommendation of Dr. Balters based on the feedback that you received the chair of surgery coin, and I really appreciate you for that. Today, Dr. Fernandez is going to talk to us about beyond the gut feeling, a new era for adhesive small bowel obstruction. Dr. Fernandez, thank you.
Can you hear me? Yeah, thank you, Dr. Rafael, for that kind of introduction. Good morning, everybody, and thank you for the opportunity to speak today. I would like to talk about a new set of ideas that are framing the adhesive small bowel obstruction in a different way. This new set of ideas, in my opinion, are challenging our current understanding and approach of the disease. I have no disclosure. Let me start by grounding us in what adhesive small bowel obstructions even matter. Why? The disease accounts for the majority of small bowel obstruction in general, and roughly 60 to 75% in the United States alone. And this translates to hundreds of thousands of hospitalizations every year. But the real burden of the disease is not just one admission. It's the recurrent admissions, the problem. The repeated hospitalizations that drives cumulative morbidity, escalating risk, cost, and long-term mortality for patients over years. And that's the first key shift I want to propose today. A new understanding, a new framing of the disease, not as a one-time event, but as a chronic disease with acute flares. And from that perspective, the decision to make decision we make at the index admission will shape the future events for the patient. Let me pause here and run a thought experiment. Imagine we had two patients who are truly identical. Same CT, same physiology, same pattern of obstruction, no differences on risk factors. The only difference between them is that one patient gets the operation during the first episode, and the other patient gets better. He was managed non-operatively, improves, right? But ultimately, the patient keeps coming back and undergoes finally surgery after the third recurrence. So if you ask yourself, are these equivalent decisions? The answer to this question depends entirely under what paradigm you're working on. If you look at each episode in isolation, both decisions seem to be reasonable. But if we see each episode as connecting and influencing the progression of the disease from a long-term perspective, they are not. They are different. A small adhesion, I'm talking about adhesives. I'm going to be referring to small bowel obstruction as adhesive, as small bowel obstruction. So it needs to be reframed because when the disease recurs, it becomes a chronic problem, meaning episodes are no longer isolated. They are connected, as we said, and progressing. Timing of interventions, recurrence, and cumulative risk will matter more than the clock. The traditional approach should be challenged because the guidelines treat them as acute events in isolation and are focused predominantly on short-term outcomes. Success should not be measured by avoiding surgery or length of stay, but by better outcomes for the patient. What I want to show you today is that the conservative framework, while safe in the short term, may be suboptimal when we think about long-term outcomes for the patients. I'm saying suboptimal, I'm not saying wrong. Recurrence is the real burden of the disease. 20% chance within 5 years, each episode increasing the probability of another one, diminishing intervals between episodes, and higher risk operations later on. This is especially reported for colorectal surgery patients, where the recurrent rates climb from about 21% after the first admission to over 40% after the second, and essentially inevitable after the fourth. This is not random occurrence. This is recurrence momentum. The recurrent reshapes the disease, and that's a key concept, creating a patient who is more likely to return and to return sooner. Historically, our traditional approach made a lot of sense. Early surgical teaching emphasized urgency. We heard that never let the sun rise or set on a bowel obstruction. Over time, as anesthesia, images, and supportive care improved, we moved toward a conservative approach, non-operative management as the default. The shift was rational. Non-operative management often works. We know that. Short-term resolution rates are high, 75 to 80%, especially when we place an NG2 to decompress, and later on we do a gastrografting challenge. And the next move is to just give the patient some time. 48 to 72 hours is the rule. But the problem is not that this approach is wrong, as I said. The problem is that the strategy became universal. If there is no indication for emergency surgery, then we should do a conservative trial first on everyone. But the disease is not universal, it's heterogeneous. An universal approach of conservative management trial for everyone may be misleading. Sorry. And because when we do conservative approach for everyone first, it might be creating the idea that waiting is the right way to go. And in reality, what we're creating is delay surgery. Before we go further, I want to pause on a subgroup of patients that traditionally has triggered a very different reflex for most of us. Small bowel obstruction in the so-called virgin abdomen. Traditionally, these patients were viewed as fundamentally different. The teaching was that a virgin abdomen meant a higher likelihood of non-adhesive pathology, a tumor, hernia, volvulus, and because of that, we were taught to have a very low tolerance for observation. The fear was always the same. What if we miss a surgical disease? That concern was reasonable at that time based on information at hand and the quality of the images. But the problem is that this approach has persisted even as the data and the images are better now. Modern data tell us something uncomfortable. Adhesions are still the most common cause of small bowel obstruction, even when the patient has never had surgery before. The malignancy rate turns out to be relatively uncommon, under 50% in contemporary series. The real change here is the CT. With modern imaging, we are no longer guessing. We can identify and confidently exclude tumors, internal hernia, closed loop, and ischemia early on. So the takeaway is not to observe everyone or to operate on everyone. The takeaway is that virgin abdomen is no longer a contraindication for conservative trial first. Our traditional thinking on small bowel obstruction has been formalized in the Bologna and East guidelines. These guidelines are excellent to define emergency surgery, but suboptimal when we're doing the non-operative management trial. In stable patients without peritonitis, no strangulation, no high-risk CT findings, the recommendation has traditionally been to wait 48 to 72 hours, often followed by a contrast challenge. Importantly, these guidelines do not take into account the recurrence of the disease. First episode, second episode, or the fifth episode are managed the same way, because each episode is treated here as acute events. These guidelines are also fundamentally anchored in time, and this can be misleading. The clock becomes the decision maker rather than anatomy, recurrence burden, or probability of failure to decide who really needs an early intervention. Here you can see that the decision points are basically depending on the clock, but they are really undefined, and you don't find anything in the algorithms, any stratificating tools to decide who might need an early intervention. This paper is often cited as evidence that gastrografting improves the management of adhesive small bowel obstruction. And at first glance, it looks convincing. Yes, patients in the gastrografting area go to the OR sooner, about 7 hours early on average. Yes, hospital length of stay is shorter. But here is the problem. Early surgery does not translate into better outcomes. In fact, complications are significantly higher, and the mortality is worse in the post-gastrografting area. You can see 5.9% versus 4.4%. So we need to ask a hard question. Are we actually treating obstruction more effectively? Or are we just repacking delay in a way that looks efficient on paper? The takeaway message is that gastrography makes us feel more confident about waiting, but no more efficient. Here is the central paradox of the adhesive small bowel obstruction management. Both operative and non-operative management can resolve the acute obstruction. Both strategies can also contribute to the future adhesive disease. The reason seems to be related to the recurrent episodes of inflammatory injury to the peritoneal cavity from repeated surgery and repeated admissions and repeated episodes of obstruction. What we have to see is that when the patient is obstructed, there is an ongoing inflammatory process. It's not just the band is there causing mechanical obstruction, it's active inflammation. And the issue is not to avoid surgery, to avoid adhesions, because both create adhesions. The real question is which one produces better outcomes for the patients. This slide represents the moment where the traditional framework starts to break and the new one begins. For decades, we treated the first episode as benign, something to get through defer surgery and deal with the recurrence later on if it happened. But this study forces us to confront a different reality. This is a large propensity match population data from Ontario, Canada, nearly 28,000 patients. It compares one single decision, operate versus observe at the very first episode. The signal is remarkably consistent. The probability of recurrence went down basically 50% from 21 to 13 if you do surgery at the index admission. This is also, and there is something subtle here if you look at the histograms. The divergence doesn't appear later. It begins on the next episode. And it persists throughout the time. This tells us that the first episode is not just an isolated event. It's a biological inflection point because it's active. So index surgery doesn't just treat the obstruction of the patient today. It changes the future for the patient. Similarly strong signal was also detected in this multi-center data across the Tennessee state. And it's telling the same story. Recurrent rate is lower if you operate on. Just with different numbers. How about the effects on mortality? Does early surgery actually save lives? When you look across contemporary data, the answer is yes, but in selected patients. This recent large meta-analysis that included over 12,000 patients shows that surgery performed within 24 hours is associated with nearly a 50% reduction in mortality, along with fewer resections and complications. Conversely, if you do the operation 24 hours, even if you have a 24 hours delay, the mortality doubles. And if you do it after 72 hours, you have a further increase in the risk-adjusted 30-day mortality. So this reinforces the point that time is not neutral. If surgery is going to happen, earlier is safer than later. And that is the key point that we can impact the management of the disease. What is particularly compelling to me is that this effect is not limited just to individual trials. It shows up at a hospital level. Hospitals that operate earlier more often for first episode of obstruction have lower 30-day mortality, with about a 17% reduction for every 10% increase in early surgery. That suggests that it's not just patient selection, it's a system behavior. Long-term data from the same population from Ontario, Canada, added another layer to the discussion. Surgery for the first episode of obstruction is associated with improved long-term survival, but the benefit seems to be mediated through prevention of recurrence. In other words, surgery saves lives by preventing repeated admissions. As we see on the Kaplan-Meier curve, you can see a better long-term survival for the surgical patients. This is a durable separation over time, suggesting that something beyond short-term physiology is at play. So what is the mechanism? The data suggests that recurrent drives mortality. Each recurrent obstruction is another hospitalization, another inflammatory insult, another opportunity for complications. NG2s, aspirations, perforations, etc. So how about when the first episode was successful, manages non-operatively on, or the patient you did an operation, but the patient comes back, now becomes a chronic disease. How does surgery affect the recurrent pattern? Longitudinal data show that surgery does not just treat the current episode, it fundamentally alters the future risk for the patient. Operative management is associated with a 73% reduction in the future recurrence. That's a structural break in the cycle of repeated obstruction. When we look at absolute numbers, the difference becomes even more tangible. 90% recurrence after surgery versus 25% with non-operative management, and far fewer patients reporting ongoing symptoms on follow-up, 35% versus 60%. This matters because each admission carries its own physiological insult, we discussed. So the takeaway here is this. For recurrent adhesive small bowel obstruction, surgery is often the intervention, and probably the only intervention that we had to brace the recurrent cycle and to improve the long-term outcome for the patients. But let's keep the discussion honest. Surgery carries higher short-term risk, particularly in older and frail patients. That's real. It cannot be ignored. But the other side of the equation is the cumulative harm. Patients managed conservatively during readmission have significantly higher mortality. So while surgery is riskier today, repeated non-operative management may be riskier over time. This is where timing and proper selection change everything. When surgery is indicated and performed earlier, within 24 hours, if we can, mortality, bowel resection rates, and complications all fall. This is exactly where the probability-based frameworks earn their value. And this is a new proposal for you guys today. If the adhesive small bowel obstruction is treated as a chronic disease, as a progressive one, the next obvious question becomes, how do we identify early who is safe to observe? Historically, we rely on physical exam, labs, and the clock. We waited for peritonitis, fever, leukocytosis, worsening pain. We basically waited for the patient to declare themselves. But by the time those signals appear, the opportunity to salvage the bowel is often already lost. This is why modern CT fundamentally changes the conversation. CT is no longer just a diagnostic tool to confirm that the patient is obstructed or not. It's a triage instrument. Multiple radiological and surgical series have shown that there are specific CT features that correlate strongly with the risk of strangulation and ischemia and the likelihood of failure of the non-operative management. Importantly, it's not about a single red flag that matters most. It's not about picking out which one has better predicted power. It's about patterns. The composite CT findings, things like closed loop configuration, mesenteric edema, free intraperitoneal fluid, reduced or absent bowel wall enhancement, and the absence of the small bowel feces sign. When they appear together, the probability of ischemia is really high, or the probability of conservative, obviously, management is really high. These patients are not stable. These patients are temporarily compensated. And when these patients with multiple high-risk features experience delayed surgery, they have higher mortality. Let me show you a couple of those signs that you should be familiar with. Here we see, obviously, a stranding or mesenteric stranding and edema. Patterns of closed loop. You can see the C loop with two transition points, bowel wall thickening and free fluid. A small bowel feces sign. Here's a point about this. A small bowel feces sign is bad when it's not present, not what it is. Because when the small bowel feces sign is present, indicates that the bowel, the mucosa, is absorbing fluid, creating the pattern. So when it's absent, it's an indication that there is ischemia. So small bowel obstruction, you can see the lack of enhancement. So when you combine, when you create a pattern, when they are combined, it's when the probability changes significantly. So why these changes practice? Because CT scan gives us, if we're willing to use it, of course, is early biological signal. It tells us when the bowel is under stress, when venous congestion is evolving, when ischemia is brewing, and when waiting is no longer benign. This is especially powerful for recurrent small bowel obstruction, adhesive small bowel obstruction, because recurrent history and the CT anatomy are not independent. With each episode, adhesions become denser, transition point more fixed, closed loop physiology more likely. But how do we translate all these findings into probabilities that could actually guide decisions at bedside? And that's where contemporary risk models are finally closing the gap. I love it because I'm a fan of artificial intelligence. And going to be this, it's going to be incorporated now in AI models, giving us real-time data and adjusting the probabilities on a daily basis. Let me show you just one example of multiple models available. But what I like about this model is that it was built specifically for adhesive small bowel obstruction. These are composite reef scores developed prospectively from a multi-center data set and externally validated specifically for this problem in patients with CT-confirmed adhesive small bowel obstruction from Finland. This is just, I'm going to use this as an example. There's still no clinical data, evidence built, that would be a cool study to do, to use it to see if it, in real life, these models are changing the outcomes. But as an example of how to use probabilities in real life. These models perform well. The Strix shows an area under the curve of 0.86. Just to remind you, any area above 0.8 is pretty good. The NOFA shows an area under the curve of 0.75. Not close to 0.8, but it's pretty good. But the real value in this model is not the area under the curve. The real value is that they force us to confirm explicit probabilities. And this is another powerful key shift today, from my opinion. Quantitative thinking in adhesive small bowel obstruction for surgical decision making. Now, let me explain about how the model performs. The Strix and NOFA separate two simple questions that we have traditionally lumped together. Number one is, what is the probability of the patient having ischemia or strangulation or a high risk of having them? That's what Strix addresses. The second one is, if the patient have no evidence of ischemia or strangulation, what is the probability of failure of the conservative management? That's what NOFA addresses. Those are fundamentally different clinical questions, and they demand different responses. What is striking is not how recurrence burden to make. What is striking is how the recurrence burden influences both models. Recurrence is not treated as a background noise. It's treated as a risk biology. The histogram on the left represent the strict risk groups along the x-axis from left to right. You can see 4 categories of groups. The low risk, less than 5%, moderate 5 between 20, high risk between 20 and 50, and very high risk more than 50%. But how do we operationalize this at bedside? How does this type of algorithm actually look like in practice? The algorithm will look like this. It will simplify the management into sequential questions. Is the patient having ischemia or strangulation? And then you run stress. And you decide if the patient is a high risk or low risk. If the patient is a high risk, obviously you take it for surgery immediately. If the patient is low risk, and then you move to NOFA to see if the conservative trial is going to fail. If it's high, then you have to decide early or plan surgery. If the patient is low or intermediate in category of NOFA, and then you put it on a trial in non-operative management. And then you do the water-soluble contrast. If it is there in the next 24 hours, you so that you know that the patient have a partial small bowel obstruction, and you can continue with that approach. If not, the patient needs surgery, hopefully in the next 20 to 48 hours, because we know now that if you do surgery after 48 hours or after 72 hours, the mortality increases and the benefit of the operation start declining. So the key here is that this model defines well when waiting is reasonable and when it becomes harmful. Once we define that the patient needs an operation, the next question is how. And this is where laparoscopy fits, not as a default, but as a strategic tool. Diagnostic laparoscopy is feasible in the majority of patients, anywhere from 60 to nearly 100% across cities, and is therapeutic in 40 to 88%. With high conversion rates, true, that span from a wide range from 0 to 50%, which tells us something important. This operation succeeds or fails before the patient even enters the operating room. And this is based on selection and timing. The most common reason for conversion is not instability, it's exposure. Dense anterior bands, adhesions, bowel necrosis, or enterotomies should trigger early conversion, not persistent. Conversion is not a complication. Delayed conversion is. We actually know who benefits from laparoscopic approach. Patients with 2 or fewer prior laparotomies, not midline incisions, prior appendectomy, and critically, patients with single band adhesion patterns on CT scan, they are very good candidates. You can see on the right side the Farinella study that some people are using hasn't been consistently good as it was when we initially published, but it's something that we can use to guide ourselves. So timing matters. Early intervention, especially during the first 24 hours, increases the likelihood that laparoscopy is safe and effective. Randomized data supports this approach. In a multi-center trial, laparoscopy lashes of adhesion resulted in shorter lengths of stay, with no increase in complications or mortality compared to open surgery. That tells us that laparoscopy is not just feasible, it's beneficial when used appropriately. So the message here is not laparoscopy for everyone. The message is earlier surgery creates an opportunity for minimal invasive surgery before the disease and the operation becomes more dangerous. And when you step back, this is really the unifying theme of everything I have discussed so far. Better timing leads to better decisions, better operations, and better long-term outcomes. So let me close by pulling this all together. The first and most important shift is conceptual. Adhesive small bowel obstruction is not an isolated event. It's a chronic disease with acute flares. And when we accept that, it becomes very difficult to justify managing every episode as if we're biologically identical. First and recurrent episodes are not equivalent. Recurring history matters. It's not just background information, it's a risk amplifier. For each episode increases the probability of failure, ischemia, and ultimately higher risk surgery. Second, we need to let go to the idea that time is our best friend, our best decision tool. It tells us very little about what's going on at the level of the bowel, about the perfusion. CT anatomy combined with recurrent burden predicts failure far better than the clock. And this leads us to the most important clarification. The future of the adhesive small bowel obstruction management is not more surgery. It's earlier surgery for the right patient. We need to avoid delay surgery and shorter smaller non-operative management for everyone. When we delay surgery in patients with high probability of failure, of ischemia, we are not being conservative, we're being dangerous. So the principle I'll leave you with is simple. Risk, not habit, should drive decisions. If we allow probability, anatomy, and recurrence biology to guide us, we can improve not just this admission, but our patient's lifetime outcomes. Thank you.
Thank you, Dr. Fernandez. Way to go. You took a controversial topic here
Yeah.
and to discuss. Questions, comments for Dr. Fernandez? This is very important. It's going to come up in ABSITE, American Board of Surgery certification, M&M, ground rounds. I'm sure we're going to have multiple opinions. Dr. Adhesive.
Question about the evidence. So it sounds like you're advocating that patients, when they have recurrent episodes of small bowel obstruction, that their risk of having more small bowel obstructions is increasing. And it sounds like the proposed mechanism for that is that these episodes of small bowel obstruction represent inflammatory events that then have cascading effects and creates more adhesions. In my mind, adhesive patterns that are serious or severe, that there's a strong band or some other anatomic configuration that leads to that obstruction, if it's bad enough, it's going to lead to more obstructions. It's going to happen again. Is there good? I would imagine it's very difficult to quantify adhesive disease other than maybe time that it takes or what you're seeing in the operating room, but that's operator dependent and other things. Is there good evidence for a bowel obstruction event leads to more adhesive disease, or are we just seeing, bad adhesion patterns cause recurrence because they're bad adhesion patterns?
So good question. There are some papers out there just trying to solve one question. Can we identify the burden of the disease? I mean, in terms of it, how will we know how much adhesions the patient have over time? I think that the answer is there are some radiological patterns. For example, when they can predict if the patient has a matted adhesions pattern versus a single band pattern. And it seems to be, I didn't bring that picture, but yes, there are images that you can see it. Direct evidence from a radiological perspective, I don't know of any of the paper answered specifically in that way. What I know is that, yes, you can assess the density of adhesions on CT. They have a particular way to do it, but it's not 100%. Ultimately, you will find out when you open the abdomen or you put the camera in. And then what we need to do is to be safe, to do good patient selection, which is a good fit for laparoscopy. You know that most likely, and if the patient is a recurrent patient that comes with 4/5 episodes of obstructions, you're going to be ready that most likely you're going to be open that patient. But the whole thing's about not to open and to do laparoscopy is what are you doing for the patient? Are you just fixing this obstruction, this hospitalization? Are you willing to change the future events? And that's what the data shows, believe it or not. There's a lot of debates on that. I mean, people that disagree with this approach. Don't take me wrong. The guidelines are still the standard of care. First episodes or recurrent episodes patient, they all go through the trial of non-operative, the non-operative measurement first, unless the patient has indication for emergency surgery. What these new ideas are trying to say is, okay, don't let the sun rise or set on small bowel obstruction. Don't feel confident because you're avoiding surgery and I'm going to just don't touch that patient. Have you seen that before, right? Don't touch this patient. It's a high-risk patient and then wait for 5-10 days until to let it go through without an operation. That idea is what is changing. Because the data is showing that you're becoming dangerous. You're against the data. What the data is telling you operate, when you have to operate on patients with first episode or recurrent episodes, you're changing the future. The data is showing that they come less frequently to the hospital. The mortality is improving. You do them first in 24 hours, everything is improving. That is what I'm talking about. And when you incorporate probabilities to predict that early on, even better.
Thank you. Excellent question. Questions, comment, Dr. Kibani?
Thank you, Dr. Fernandez, for the excellent talk. I mean, ignore my, it's been a couple of years, so.
You're still a general surgeon.
Ignore
Dr.
my
Giovanni, I can
You're
take
still a
ignorance
general
in some of
surgeon.
these questions.
Yeah.
So I agree. I think it sounds like we are back to don't let the sun rise, come for and sit on the
Correct.
small
We're
bowel
back.
obstruction.
That is correct.
How much validation is done for that risk calculator that you have?
No, that I just put it as an example. That's what I said. There is, we haven't seen any paper yet, but that's one of my intentions is to try to use it.
Proposal.
Yeah, to have a prospective trials unit, using it.
Good. I do have one other question, a little bit more controversial. It goes back to some of the M&M we just talked about. Who should admit these patients with a small bowel obstruction?
I like your question, Dr. Cuba.
From this data, it should be
Comes
surgical.
into the ER.
The surgery service, no question. Because that is what been feeding the notions of, oh, this patient is well treated. If you don't have to operate, admit those patients to the medicine service. So the surgeon kind of feels relief that now it's on the medical side, call me if things go down the road. This changes completely the paradigm, in my opinion.
What do you think what does the data suggest? Who should admit these as small bowel obstruction come to the ER?
The data is suggesting that the services, the surgery service, no question. Because they can run, the surgeons run the algorithm. I didn't show you one piece of information, regardless the new use of gastrography. The guideline sits on the idea that you have to wait for 48 hours before you order a gastrography challenge. But based on the data, the EASE guideline updated the recommendation last year. And they are now talking about doing gastrographic challenge 6 hours after NG2 decompression. And the idea is this: you need to decompress first. You don't want to, get more contrast and dilate an already obstructed bowel because the risk of perforation, vomiting, and aspiration is there. You need the NG2 decompression of 6 hours, and then you do the gastrographic challenge. And you need an answer in the next 24 hours to get the benefit of mortality benefit of the early operation. So that is what has changed significantly, at least in the paradigm. The EASE guideline is aware of the data. They are not telling you, they are not using the model, the predictive tools, but they are saying, hey, what we need to do now is, in order to avoid the delay, is to do early gastrographic challenge. Not do it at 48 hours because the mortality increases. Do it the first 24 hours, and they put it right now 6 to 24. My practice is I put an NG2, I decompress for 6 hours, and then I take the patient, I order the gastrographic challenge if I do the conservative approach.
Dr. Ewing, you have a question?
I would say, yes. The ACS team nearly universally agrees that these should be admitted to us. One of the cultural challenges we have here is that oftentimes the ER providers do not call us until they don't call us, and medicine calls us after admitting. I think as Dr. Punjo works on our ACS guidelines for ACS verification, we're trying to create a set of guidelines for the ER providers because diverticulitis, gallstone pancreatitis, and small bowel obstructions routinely get admitted to medicine, and we don't even get called for sometimes days. And I've gotten personally a lot of pushback, and my interns have gotten pushback when we tried to take over the patient from overnight medicine staff. So it's just a lot of education that's needed. But I think we all recognize the need for it, and we all try to take over when appropriate. But it's like a systemic thing. And our ER providers have turned over so much that we need new ER education as well as medicine education to really get this home for everyone.
I appreciate bringing it up, and I'm in full support and agreement with what you said, Dr. Ewing. Other comments or questions from Zoom or in person? Dr. Anker.
Thanks very much. That was a very, very lucid and coherent presentation, well executed. You without saying it, clearly implied that small bowel obstruction is not just a disease, it's a spectrum of disease, right? So you have very many different conditions. I think one of the problems we're faced with, obviously, is that we get consulted with the diagnosis of small bowel obstruction very often on a CT report. And many of these patients turn out to have ileus. Even just last week, I had a case like this where a preliminary report described an obstruction. Everybody got excited. I took it back to the radiologist and looked at it and said, you know, it looks to me like there's a tapering here and no distinct point of obstruction. So having lived in those days where the mantra was, no, don't let the sun rise or set, I recall many negative laparotomies we performed that turned out to be non-therapeutic because all we found was a taper. So I think now we're much better equipped. Like you mentioned, CT resolution is much better. The experience has advanced a lot. We get in a scenario where we can look at predictive factors like you've mentioned. So like I say, I agree with your thesis, but it still remains a difficult problem in that very often we're called on these patients that turn out to have ileus. So do you have any comment about how you make that distinction? Is it a clinical distinction? Is it going to be more image guided? And the other thing I'd like you to address is how do you feel about serial CTs? Because I've been seeing the CT scan overused almost as a substitute for physical exam. And the role of pain to me is much more important than the CT imaging.
Excellent questions.
Yes.
We'll close with
I'm gonna-
Dr.
Thank you. I'm going to be addressing the first question, how you differentiate ileus, obviously, versus small bowel obstruction. We all know the definition of small bowel obstruction, right? The radiological definition, the diameter more than 3 centimeters, the requirement of a transition point, not necessarily transition, but at least a discrepancy, significant discrepancy in the diameters, and with air fluid levels, but suggest and a small bowel obstruction. Even this definition can be represented also in ileus because there is always the questions if it's a transition point or just peristalsis, giving you the idea that might be an obstruction, and they put it a small bowel obstruction versus ileus. It's a very common read, right? And then what to do about it? And then one of people say, okay, because you're using contrast study, the PO, repeat the CT with PO contrast in the next 6 to 12 hours, or repeat and do a gastrographic challenge to see if it's real obstruction or not real obstruction. So I don't think that there is a clear cut, but in my opinion, we all know when we're seeing bowel obstruction on images, and when it's kind of blurry, ileus, or most likely is not there. Is that my personal experience? When in doubt, I always repeat the images in 6 to 12 hours. I repeat the images in 6 hours to answer the second question is when to do it. When there is uncertainty about a serious problem. For example, there's not quite clear evidence that there is ischemia. In this predictive model, that's the missing aspect. They don't address when to repeat the images. And I think it's the next questions. Particularly, I have my personal algorithm like doing it in 6 hours because I'm running against the clock. So the change of the paradigm here is not that the clock is your best friend. Now the message is running against the patient, it's running against you. You're delaying surgery, you are compromising the future of the mortality benefit of the patient if you have to operate. So I'm moving my algorithm to early small bowel follow-through to see if the patient is going to declare or not for surgery or not. And if any questions, I'm not going to sit on radiology waiting, oh, they said that it was negative, there's no evidence of ischemia or strangulation. I normally repeat my CAT scan in 6 hours. You might make the argument in 12 hours, but again and again, you're running against the clock. In 6 hours, there's still no evidence of ischemia. There's still evidence of worsening. I will probably feel more reassured that I'm doing the right approach. But still, you will need data to prove this idea.
Thank you. I really appreciate you giving this ground round. It's an excellent ground round. It's a very important topic. And I want to thank Dr. Patel for proposing the idea of videoing all ground rounds. So for everyone, I'll remind you, this is videoed. It's on the website. You can listen to it and watch later. Thanks again. I appreciate you taking the time. If I can ask everyone, I'm going to invite Dr. Punjit, the president of the ACS chapter, to say a few words about the meeting in April. And I want everyone in this room to support his presidency, attend the meeting, and participate in that. Dr. Punjit.
Good morning, everyone. So, the ACS Nebraska chapter spring meeting is coming up the end of April. So that's the 24th of April on a Friday. And we also have an event this evening, actually, which is the new initiates into the ACS into the ACS. And that's going to be in Aksarban starting at 6 p.m. at DJ's Dugout. So, everyone who can make it, please do. As far as the ACS Nebraska chapter, two things. So one is the skills competition. We'd like to have people from here participating and obviously helping us beat UNMC in that competition. In the past, we've done a quiz, but I think we moved away from that. We're trying to do the skills competition. In addition, the other thing will be the abstract competition, which is open to med students and residents. The submission date for that is February 15th, so be sure to please submit. Last time we really didn't have much of a presence at the chapter, and I'd like to see more from our residency. And try and get involved as much as you can. I know we have a few residents who are involved, Dylan, Sebastian. Really, it's a good opportunity to network, possibly find mentors for the future, get involved in different projects, advocacy, whatnot. There's opportunities there, so just try and get involved.
Thank you, Dr. Punja. And I'm going to close with a note of gratitude to the trauma team. Today is an example of a proud day for trauma. The ACS chapter president is from the trauma team, our PD is from the trauma team, and we had a wonderful ground round. So let's give the trauma team a round of applause for all the hard work they're doing. Thanks again.